Right, 10 minutes to talk about all the research in behavior and mental health. I'm going to give you the, the big conclusion first. And Dr. Musa actually said this on the panel earlier, that we do have data. It's not necessarily generalizable. So unfortunately, what we're not going to be able to tell you, and I'm just going to give you the broad strokes, I'm not going to go into details of studies, but what we can't tell you is which individual children are going to have better or worse outcomes. And what we can't tell you is what interventions work for individual children. So that is not going to be in here. But I'll try to give you the big brush strokes, and I'll try to go quickly. All right, so basically just a quick overview. I'm going to talk about domains of behavior, the limitations of some of the research that we have, what the research does tell us, and what sort of the remaining questions are. I'm not going to talk much about temporal lobe epilepsy and temporal lobectomy or corpus callosotomy. We actually do have some specific research on that, and talk to me outside of this, but I'm going to leave that aside for now. All right, so when Monica asked me, okay, give an overview, it's a patient-centered outcomes research conference, give an overview of the research, I made my outline, I said, what I'm gonna do is talk about all the domains clinically that parents talk to me about, and I'm gonna go to the literature and talk about what the outcomes are and kind of what the interventions are. So here are some of the things as a clinician that I hear parents talk about, and you kind of heard this earlier from some other people, but sort of those big, aggressive safety concerns, disruptive behaviors, tantrums, oppositional behaviors, the repetitive sensory-seeking behaviors, impulsivity, dysregulation. You can read these, low mood, that kind of thing. So I was going to go through this. I looked at the literature. Yeah, no, that's nothing like that is out there. There's nothing that specific. Here's a bear. I can offer you that. Bears are good. Nothing like that out there. Bears always make me feel better when I can't. And there are a lot of issues with the existing studies. A lot of them are great studies. I've been an author on some of them. There are authors in the audience. But there are limitations in terms of telling us what we want to know about our individual children, right? And you heard, actually, Dr. Musa went through a lot of these for the cognitive studies, so some of these are going to be repeats, which is good because I can speed up. But most of the studies we have, because we're talking about a very rare kind of condition and very rare surgeries, and there's not a huge group of 8-year-olds who develop Rasmussen's in the left hemisphere and undergo surgery at age 12, and then we look at them at age 15. That doesn't exist. So the studies that do exist group together different types of surgeries, different types of etiologies, so what led to the need for surgery. Many of them don't have pre-surgical information. We talked about that earlier. Sometimes you can't even get it. We're talking about little kids. A lot of the behavioral studies use, they need to, parent report. And the two things that mostly the studies report on when they're talking about behavior use the CBCL, which is the Child Behavior Checklist. So it's a parent rating of specific behaviors. And it compares children to other children, typically developing children their age. So the CBCL is one that we see a lot, or the DSM, which is the Diagnostic Statistical Manual. So most of the research either has scores on this checklist, on this rating scale, or meeting diagnostic criteria or not. Or some studies actually make their own questionnaires and say yes or no, does your child have behavior? So that's kind of an issue. We'll talk about that a little bit more. The age range is huge, the age range of surgery, the age range of outcome. The follow-up time varies. A lot of the studies are short-term follow-up. But we heard earlier that actually the long-term, Abby talked about the long-term outcome, we just don't know. And even the studies that look 2 years out are saying, hey, things are different at 2 years than they were at 3 months. We don't have that. A lot of studies look at seizure freedom as a predictor. It's a huge predictor. Things are better if you're seizure-free for most of our outcomes, but that's not the whole story, and there are a lot of factors that studies just can't look at or we haven't looked at. A lot of studies don't have control groups. Somebody mentioned earlier, you really want that group. Well, we don't want them, but the group that should have had surgery and didn't, we don't have that group. That doesn't exist. and a lot of studies looking at behavior and mood, and there are about 20, 25 reasonable studies that I found talk about behavior or mood, and really don't break it down into all those domains that parents are really talking about. All right, so what can we say? There are a few things we can say, again, generalities with all kids lumped together. In general, children with epilepsy, forget surgery, forget whatever, children with epilepsy have higher rates of mood and behavior concerns. We can also say that in general, everyone lumped together, children pre-surgery, so surgical candidates, have higher rates of behavioral and mood concerns. In general, the studies show that short term, there is either a stability or an improvement in behavioral and mood concerns after surgery. Now, we heard earlier about depression, and there's so much variability, but that's sort of a general global statement. We also heard earlier, some of the authors are in this room, that there might be some longer-term improvements that we didn't know, that you may not see 3 months, but 2 years later you may see improvements in some areas. But also you might see some worsening in some areas, or a further drop compared to age peers, a further widening of the gap, if you will. And again, seizure freedom in most studies show better improvement, not more improvement, but better mood and behavior than children who don't have seizure control. So those are the broad strokes. Again, there's so many caveats. What we also can say is it depends on the underlying cause. There's some research that shows, or several studies that show that the more developmental etiologies tend to have more behavior and mood problems than the more acquired etiologies. Depends on which part of the brain. We know different parts of the brain have different things to do with impulse control and attention and mood and all of those kind of things. So there is some variability depending on what part of the brain is involved and what part of the brain is resected. Age and duration of seizures, we saw that earlier today. That can impact outcome, but that's also really tied to etiology and cause and severity and a whole bunch of other factors. Medications, it's sometimes hard to tease apart what's, pre-surgically, what's the medication, what's the underlying condition, what is the seizures. That's a piece that we can't really tease apart very well. And honestly, a lot of this probably depends on stuff that we're not even measuring. We learn more and more about genetic underpinnings, and not just the child's genetics, but the family genetics. We heard about preconception health and genetics. There's a lot of stuff that probably this depends on that we aren't even really studying. Here are some specifics. I'm not going to go into details about all the studies, but just this is from the ILAE review. Monica said no references, so this is how I got around that by putting like a little bit of a reference, but not the whole thing. These are just children with epilepsy, not pre-surgical, not post-surgical, not even surgical candidates, just children with epilepsy. And look at the rates of anxiety, depression, psychiatric disturbances, ADHD, autism spectrum disorder. There's some research, even if you don't meet criteria for autism spectrum disorder, and we were talking about this earlier, some of those symptoms, the repetitive sensory behaviors, you see that in children with epilepsy, all children with epilepsy, and often you see these things before the first seizure. So what that tells us is there's something in that underlying neurological condition that's leading to a lot of these things. And so before you even talk about surgical effects, right, we need to understand that better. There are a few studies looking at hemispherectomy. I hope I do justice to the people in this room. Luckily, one of them I was an author on. But about 27% have significant behavioral problems pre-surgery. Varies by etiology, varies by severity, varies by age, but that's roughly. Seizure return is associated with more symptoms post-surgery. But the studies that are out there, if you look at just any improvement, about 92% of patients have some improvement in some domain of behavior and mood. In another study, significant, so statistically significant improvement, about 50–60% are going to show statistically significant change in one domain or another. Still can't predict who, though. For the more sort of major lobe resections, not hemispherectomy, there are a bunch of studies that can kind of summarize. Basically, getting down a little more specific in these studies, there are some improvements shown in externalizing behavior. That's that like aggressive, impulsive, acting out behaviors. Some improvement in attention, social skills, and aggressive behaviors. The non-surgical kids, so kids when they do have a control group and children don't have surgery, regardless of seizures or no seizures that follow up, the non-surgical kids have more anxiety and depression at follow-up. But in these studies, there was sort of a review that kind of put all the studies together. About half had some kind of mental health diagnosis post. Now, this is that DSM, the checklist, right? You have to meet certain criteria, and here's your label. But about half met criteria for something at follow-up. ADHD, OCD, conduct disorder, DBD is disruptive behavior disorder. It's a new one, but that's in the new DSM. Emotional disorders, psychiatric, autism spectrum. All right. In studies that sort of lumped all different types of resections, including some of the temporal and smaller resections, about half of the kids improved in at least one domain. That's sort of raw improvement, so attention, aggression, impulsivity, rule breaking. About 25% got worse in at least one domain. So again, impulsivity, aggression, and attention were the worsening ones. But at 2 years post, about 60% had at least one domain in the abnormal range. And again, it's late, so I won't go through all of the numbers, but here they are, the percent of kids that were elevated in those domains, if you're interested. All right. A couple other, so that's like the big, broad strokes. A couple relevant studies, I think, as we're talking about what do we need to do next, I think we need to think about. Certainly, we don't have these long-term follow-ups. We don't have these long-term outcomes. And I read that bad study, I forget who was talking about it, the long-term outcomes. There are only one or two, it was bad. There are only one or two long-term studies, and what it shows is that that's not necessarily, we don't necessarily see the same things long-term as we see at 3 months or 1 year or 2 years. And this study, I'm sorry if it was your study. The study, there was a recent study that showed that social skills actually improved 2 years out, which they hadn't improved at 3 months and 1 year. So it may take some time for kids to learn strategies and learn how to regulate their behavior, and maybe we're not looking far enough out, and then we would know better sort of how to intervene. I also want to make the point that we know parent report and teacher report and child report, if we can get it, do not correlate. And in fact, all the studies, almost all the studies use parent report, and we don't necessarily know how our kids are feeling, or if they're depressed, or if their behavior they're showing is because of anxiety versus aggression. We don't know. And so as much as we can, we need to get those other perspectives and measure things in different ways, not just parent report. I also want to, and parent report is reported by parents who are stressed and maybe are anxious, and that actually correlates with their report. And so that's another caveat. There's nothing wrong with that, but that's another caveat to parent report. And I also want to make the point that quality of life studies actually show that a child's mood is much more related to their quality of life than seizure control or other kinds of medical factors. So I think behavior and mood is really, really critical, but I don't think we have enough information to say, do you want me to speed up, Monica? We have a little bit of information, like I alluded to earlier, about specific predictors, but again, this is sort of group data. So I'll leave this here. I'm happy to talk about it more. Again, nothing consistent with side of surgery, and some of you have heard me talk about data I have on executive functioning and mood and behavior and trying to look at side of surgery. Our kids don't work like that. Side of surgery is not necessarily what we would expect in an adult with a stroke, for example. All right. What can't we say? Unfortunately, what we can't say is individual children who will have behavioral problems. We have some predictors, like we just talked about, but we can't say for individual kids who are going to have problems, who will improve or who will get worse. What interventions work? I work in rehab, and so this is what I always come down to. Like, well, what can we do about it? Here's your child. Here's what can we do? What can we make them as functional and with the best life that we can? We don't know how to reduce the risk. If it's surgery, if it's sending someone to an endocrinologist at 3 months, even if they're not having symptoms, we don't know what reduces the risk. And you know, researchers, we look at statistics, we look at numbers, we like numbers. We say, oh, a statistically significant difference but we don't really know what's a clinical meaningful difference for families. And I think that's awesome that we're having this conversation, because that's what this meeting is all about. So that's all I have. Here are 2 pandas, and I'm happy to talk more about any of these things in more detail. Thank you.